like to say is, when you're doing master health checkup, please, as a protocol, start doing PVR for all the women in the perimenopausal, even younger patient, because post-void residue will tell us about any incidence of not just the infection, but the incontinence and the back pressures to the kidneys and the reason why a CKD can come. So if you make it a protocol, that goes a long way in the management for us. Thank you, and please continue with the CME.
Thank you, ma'am. Thank you so much for this clinical perspective and sharing your clinical knowledge so that we can follow this and in our routine practice and try to give as much as information to the patients. With this ma'am's perspective, I would like Dr. Rohan to start the talk for today so that we can start. I will have a very fruitful discussion going ahead. Over to you, Rohan.
Yes. Okay, so good afternoon, everyone. And I would continue the topic. Today's topic is early clues, lasting impact, NT-scan, uterine Doppler, and the cervical assessment. So the introduction, early pregnancy, as just now ma'am has said, is the actual window of opportunity to us. And the key predictors here are NT-scan, uterine Doppler, and the cervical length. So what is the impact? Early detection of aneuploidies, then preeclampsia and preterm birth. And our ultimate goal is to improve the maternal and perinatal outcomes. So what is NT-scan? NT-scan is nothing but basically it is the measurement of the nuchal translucency, and it is a collection of fluid under the skin behind the fetal neck in the first trimester of pregnancy. And the term translucency is used irrespective of whether it is septated or not, and whether it is confined to the neck or envelops the whole fetus. In fetuses with chromosomal abnormalities, cardiac defects, and many genetic syndromes, the nuchal translucency is increased. So what is the method? So basically, we have a very specific age for measuring the NT, that is the 11 to 13 plus 6 weeks of gestational age. That to be much more specific, gives us the CRL of 45 to 84 mm. So we only do this scan in between the CRL crown rump length of 45 to 84 mm, and independent of whether it is septated or confined to the neck or whole fetus. So what is the importance of doing this scan? That is it is the major tool in the first trimester aneuploidy screening. And it detects the risk of chromosomal defects like the trisomies, the Turner, and triploidies, then structural anomalies like cardiac, diaphragmatic hernia, skeletal, body stalk deformities, and other anomalies, genetic syndromes, and also allows us for early counseling and early intervention. So the measurement technique here, we'll be taking a mid-sagittal section. The fetus should be in neutral position. So I'll let the image speak over here. So this is a perfect mid-sagittal section where the image is properly zoomed in, where we can see the majority of the image is occupied by the fetal head and the thorax, and it should be in neutral position. So we can see a pocket of AFI, amniotic fluid over here where my pointer is. And then in the mid-sagittal section, we can see the nasal bone over here, then the thalamus, the midbrain, the brainstem, the intracranial translucency, the cisterna magna, and then the NT. The care is to be taken that there is we are able to differentiate with the pocket of fluid here, so that we accidentally will not be like measuring the amnion. So care should be taken that we are actually measuring the NT. So how are we going to place our calipers? So if you see, the calipers are basically by the symbol of plus. So the horizontal line should coincide with the hyperechoic line here. So it should go with the horizontal line coinciding with the hyperechoic line. So it is like this, which is here pictorial representation. So up till now, there's the image on the left shows us the basic NT scan format, or the basic protocol we used to do. Is the first image is over here is again the neutral position of the fetus, the entire fetus in the mid sag section. We can get a crown rump length over here, then followed by the biparietal diameter, and then the abdominal circumference, the female length over here, then the NT as I described earlier, then the ductus venosus Doppler, and tricuspid valve waveform, where we put the Doppler on the tricuspid valve to check for regurgitation, and the uterine artery Doppler. So the risk calculation. So NT is incorporated into patient-specific risk for aneuploidy. So the risk is given with maternal age plus the gestation and the NT likelihood ratio. So what are the detection rates? This is a very important table which I have taken from the booklet of the Fetal Medicine Foundation 11 to 13 week scan from the FMF website. So it gives us a perspective that if we go by the maternal age alone, the detection rate for the screening is just 30%. All of us know that the higher the maternal age, the higher the chances of having chromosomal abnormalities. So if we combine the maternal serum biochemistry, that is the double marker test, with maternal age, we can get up to 50 to 70% of the detection rate. If we do maternal age plus fetal NT alone, we can get 70 to 80%. If we go with maternal age with fetal NT and the combined serum biochemistry, we can get 85 to 90% of detection rate. And if we move on to maternal age, fetal NT and fetal nasal bone, which is up till here is what the general radiology protocol is going on. So we can get the detection rate of 90%. But recent advances, what we do is maternal age plus the fetal NT along with the nasal bone and the maternal serum free beta HCG and PAPA at 11 to 13 weeks of scan can give us detection rate of up to 95%. So this is what we are aiming for. And also I would like to add a note that I have also seen many a times that the patients are not properly counseled that they have to give the sample for the combined biochemistry within the 24 hours of doing the NT scan. So what happens is if they don't give it, the values are not valid because the CRL increases day by day. So the patient should give the sample within 24 hours of doing the NT scan. So the outcomes with increased NT. So how and what is the cutoff for NT? How much is the increased NT, or what is the value where we can say that the NT is high or it is normal? So it is the NT more than 95th centile for the given CRL. Usually the common cutoff value we consider is more than 3.5 mm, but that is not very specific. So we go by the charts. So NT more than 95th centile for the CRL, we will consider it as it is an increased NT. Hence, we need some calculation softwares for that also. So if we have an access to a software, that is very great, that every practicing radiologist, sonologist, OG-SHIAN, or even fetal medicine people should have. But if we don't have access, we can also go to websites, certain websites like perinatology.com, and we can use that where we get the centiles for the specific CRL and the NT values that we put in. But what software allows us is gives an extra edge over a lot of things, especially like when we want to differentiate between IUGR small for gestational age, when in specific cases where we want to know about the exact growth, whether it is constitutional delay, whether the patient is diabetic, whether the baby is large for gestational age, in these things, and to plot growth, the softwares are very important. And I would like to add a note here that we at Vijaya Diagnostics are very soon acquiring one. So I'll continue forward. Higher the NT, higher the risk of chromosomal abnormalities. It is associated with miscarriages, fetal death, and also congenital malformations. And even with normal karyotype, if the NT is increased, it is linked to cardiac defects, like risk rises with as the NT thickness increases, and developmental delay in small number of cases. So importance of other markers. So now NT is not just about NT, it is also about other markers like the nasal bone. So at NT scan, the nasal bone is absent in about 60 to 70% of trisomy 21 fetuses, and in about 50% of trisomy 18 fetuses and 30% of trisomy 13 fetuses, and in about 2% of chromosomally normal fetuses. So hence it shows us how important it is to document the nasal bone, whether it is ossified, unossified, it is uh, partially ossified. We have to document it very clearly. And abnormalities in the flow velocity waveform of the ductus venosus are observed in about 80% of the fetuses with trisomy 21 and in 5% of chromosomally normal fetuses. So this also gives us the edge about how important it is to document the Dopplers. So clinical integration. Now NT is part of first trimester combined screening, and it should be offered with maternal age, serum biochemistry, then additional markers like nasal bone, DV, tricuspid flow, and now that ISOG has come up with recent guidelines, now NT scan is no longer just a scan of the above mentioned things, but it has become the new early anomaly scan, as we call it, and it has become a detailed protocol has been set forward. For example, I would like to list a few things that we also see in the NT scan is looking at the fetal kidneys, the renal artery, the four-chamber view, the three-vessel trachea view. So it gives us, we also look at the situs of the baby, which is very important. So if we know that there are certain abnormalities, we can intervene very early. So comprehensive risk assessment guides offer to invasive testing, or even we can go for NIPT. So I'll move forward with the next topic, that is the uterine artery Doppler. So its definition and purpose. Non-invasive method to assess uteroplacental circulation, performed in the first trimester at 11 to 13 plus 6 weeks, and detects impaired trophoblastic invasion of the spiral arteries, and it is an early predictor of preeclampsia and IUGR. So physiological background. In normal pregnancy, the uterine artery resistance decreases as trophoblasts invade the spiral arteries. Abnormal placentation leads to persistence of high resistance flow, hence leading to placental hypoperfusion, and the risk of maternal and fetal complications increase. So what is the technique, the proper technique? So the approach is transabdominal ultrasound. We identify the uterine arteries at the crossover with external iliac arteries, use the color Doppler to confirm the vessels, then place the sample volume approximately 1 centimeter distal to the crossover point, and we record the PI and the presence or absence of the early diastolic notch. So the interpretation. So normally we get a low pulsatility index and there's absence of notch, but if the findings are abnormal, we get high pulsatility index and there's persistence of early diastolic notch. So bilateral notches and high mean PI gives us, it is a strong predictor of adverse outcome. Again, I would like to add a note over here that many calculators are available online, but the better thing is to get a software and put the values so we get the centiles for the specific age. So this slide shows us the normal waveform. So whatever pictorial slides I'm going to present from here on are taken from the ISOG and the recent articles. So here we can see there's no diastolic notching and there's a proper forward flow in the uterine artery. So this is a normal flow. And now the abnormal uterine artery waveform, we can see the arrow, white arrow on the screen, which shows us the increased resistance with the notch. So there's notching, which is abnormal. So what is the clinical significance? Whenever there's high pulsatility index or there's persistent notch, it gives increased risk of preeclampsia, especially early onset, and IUGR, and hence ultimately adverse perinatal outcome. So best used in combination with maternal history and biomarkers for risk stratification. Now the integration into screening. It forms a part of first trimester preeclampsia screening, and it is combined with maternal risk factors like the age, the BMI, the parity, and the medical history, then mean arterial pressure, maternal serum markers like the PAP-A and placental growth factor, and it helps us identify high-risk women. So we can intervene early and start aspirin prophylaxis around before 16 weeks. So what is the usual chronology that happens? So uteroplacental failure, the sequential well-being changes which happen in the fetus are as follows. So the graph starts from the left side of our screen. Whenever there's decreased growth, there's cerebral blood flow increase in MCA. That is essentially nothing but the brain sparing effect, we call it. The fetal reserves the maximum blood flow for the brain. Then there's a reduction in the growth of the fetus. So hence the fetal size less than 5th centile, the head circumference and the abdominal circumference. The the umbilical artery pulsatility index also increases. Hence we get a pathological CP ratio. And there's moderate to severe redistribution further on, which leads to decrease in AFI and ultimately oligohydramnios, and then ultimately the abnormal venous blood flow in DV. So what is the take-home message? So Doppler investigations give insight into fetal and pregnancy pathophysiology. Doppler is one of the major breakthroughs in fetal medicine. Can be used in all trimesters for different indications. It can be used as a screening or a diagnostic tool according to the circumstances. In second or third trimester, it can indicate abnormal placentation, fetal hypoxia, fetal anemia, and impending heart failure. Like I'll give you an example, that is in the cases of Rh positive pregnancy, we use the MCA Doppler for checking the fetal anemia. We check the peak systolic velocity of the MCA. So we get to know whether the fetal is going into anemia or not. So my next topic, the cervical assessment. So short cervix is the strongest predictor of spontaneous preterm birth. Early identification allows timely prevention and reduces morbidity and mortality associated with prematurity. So what is the ideal time to perform a cervical length scan? So according to the ACOG and the Society of Maternal Fetal Medicine, transvaginal ultrasound scan for cervical length done in between 16 to 24 weeks. But we should start doing it as soon as the NT scan. Whenever a patient comes for NT scan, we should put a transvaginal scan for cervix. So the methods of assessment, first, as the obvious one, the transvaginal ultrasound, which is preferred and gold standard. The other is transabdominal, which has limited accuracy and mainly it's for screening. But I have seen many a times when there are the measurements go haywire. So I suggest, or I have read in multiple articles, and this is the common gold standard, is always go for transvaginal approach. So the technique now. So we'll ask the patient to empty her bladder, then we'll give her the lithotomy or semi-recumbent position, and the probe is placed in anterior fornix. So I'll let the picture speak over here. So the picture on the left side shows the TVS probe within, and it is in the anterior fornix after the patient has emptied the bladder. And picture on the right shows us both the external os over here and the internal os. So why empty bladder? So full bladder, it can artificially increase the cervical length by putting undue pressure and can obscure the presence of cervical funneling. Many times it will obscure. So it's better to do a transvaginal scan on empty bladder. So what is the landmark of identifying the correct cervical length, and how do we know that we have to take it at the correct location? Is visualizing the cervical mucosa. We'll see the cervical mucosa as seen in the right side of the right image over here is the hyperechoic line, which has the cervical canal in between. So what is normal cervix and short cervix? So basically the normal cervix is what looks like this on the left side of our screen. And the short cervix is on the right side of the screen, where we also see the funneling over here. And the only functional length that is available for us is this much, which is marked with the arrow. We have to also take care of the segmental contractions that occur and which can pseudo lengthen the cervix, and the performer, the scan, whosoever is doing the scan, he should know whether it is segmental contractions, and he should be able to differentiate the actual cervical length. So the proper technique to visualize and measure the cervix with vaginal sonography is exert some pressure to identify the cervix and cervical canal, that is after inserting, and then slowly release completely the pressure to measure the cervical length. Sometimes you also have to retract the probe a little bit just to let the pressure off and measure the cervical length. So normally the cervical length is considered to be at least 3 centimeter and above. If the length is between 30 to 25 mm, so the risk is mildly elevated of spontaneous preterm birth and needs attention of the obstetrician. But if the length is less than 25 mm, it is short cervix and it has very high risk of spontaneous preterm birth and warrants an intervention. So cervical incompetence is nothing but it refers to painless spontaneous dilatation of the cervix and is common cause of second trimester pregnancy failure. So the key points, the transvaginal approach should be used in preference to the transabdominal approach when examining the cervix. The correct technique should always be used as I explained above, and care should be taken not to overestimate the cervical length. Excessive pressure with the probe should be avoided when measuring the cervical length. Thank you.
Thank you, Rohan, for enlightening with the crisp talk. Ma'am, is there any?
Yes. Thank you, Rohan. First thing, I totally agree when you said 16 to 18 weeks is the time when because that is the time when we put the cerclage. But what we need to know is if we do a scan at 13 weeks, what we are going to gain is first, there are no major abnormalities. That is the very important thing before we put a stitch. When we put a stitch, we have to put a stitch on where a baby is. Major abnormalities are not there. That is first point. Second, then we follow the next scan at 16 weeks to repeat scan at 16 weeks. If we see if it's shortened, it stayed shortened, or after giving a progesterone therapy, did it increase? So accordingly, we put the cerclage at 16 to 18 weeks. So we don't put the cerclage at 13 weeks, but that is our basis on which we take a call whether we add progesterone or we have a follow-up scan. And most important criteria for cerclage is previous preterm. Irrespective of what you do. See, we do not do elastogram with cervix. But what is important is not just the length, but the quality of cervix is also equally important. Unfortunately, we do not know how to do it. And so we only look at length and we put the cerclage and we add progesterone injections or tablets, which will allow us to prevent the preterm. Unfortunately, in spite of all that, the cervix being 3, 4, suddenly they can still have a preterm, especially with the history of preterm before. So this is something we need to understand. It's not the blame game. Then usually gynecologists will say, you said 4, we did not put the cerclage. That's when it happened. So the thing there is about the consistency of the cervix, the amount of fiber in it, collagen in it, and the water content in it is what we look at. Next, NT, I'm sure you covered it very well, so I don't think we need to be worried. But what I liked in what you said is about the contraction part of it. Most of the time when the contractions come, what we see is evidence of fibroid. This is the thing which usually radiologists start giving us, and that gives us a nightmare because that is an indication on which we end up doing cesarean, not vaginal delivery, because we think that fibroid complicating pregnancy will start coming on the top. And when we do cesarean, the patient keeps asking, please remove fibroid also. Then we keep searching for the fibroid. So we need to understand the difference between contraction of the myoma and the fibroid. That is very important, because if it is a myoma and the placenta is adherent to it, the chance of adherent placenta is much, much, much higher than just when the contraction is there. This is a point which I thought we will tell. And Dopplers, you covered well, because that is very important in today's time to do the Doppler for IUGR and the preterm. Reason being, and more infertility patients and IVF patients start coming, and we are seeing aging patients, elderly primaries coming up, where we are seeing increased incidence of PIH and hypertension and IUGR per se. And what is even more troubling in the recent times is, in spite of us telling everything, and if it turns out to be severe IUGR, again, asymmetric IUGR is something which we will not be able to predict by this thing. Just the blood flow and the outcomes are what which will tell us that how to go about with it. But therapies have changed a lot. So that really helps us in, if you guys can help us in how to go about with it. So fetal medicine department only emerged because of all these things which came out. So, and another thing in the first trimester, what all we can do. I think a comment when you're doing the yolk sac size is something which is really important. Like yolk sac present regular, general gestation sac regular is okay, but the size of the yolk sac goes a long way, giving out that it's going to be viable in the long run, abnormal child in the long run. That is one more point which we see. Vanishing twin syndrome, we know that quite a few of high vanishing twins will be there. So that is one point which we can see almost 8% will be going into vanishing twin syndrome. Then anything else, Vijayanand?
No, ma'am, I have a small doubt. Now that there is, suppose we consider that nuchal translucency is normal.
Normal.
Okay, no. And then we have abnormal HCG and PAPE.
Doesn't matter. See, that's the reason now with 11 weeks we are doing the pentamarker test. Okay. Oh. We don't take one thing. We look at HCG, we look at PAPE, we look at PLGF, we look at inhibin and alpha fetoprotein.
Okay. So
5 markers.
Okay, 5
it's all changed now. So pentamarker will look into, so we have PLGF. So PLGF plus the age of the patient, plus the gestational age, plus the Dopplers. All 4 are taken and then the nomogram comes. That is why when you people give at this and then give double marker, I just ignore and again send for pentamarker. Because double marker is only 75% is the sensitivity, 76% to be said. But here PLGF is almost 99% sensitive. So we look at pentamarker test and then people in twins, we go for quadruple marker test. We do not do pentamarker test. So this is the way we do it. And then when as we reach, the PLGF is the most important thing. More than 100 is normal. 12 to 100 is hypertension, and it's going to affect the blood supply to the baby. Less than 12 is imminent and we'll have to take out the baby. So all these things help us in the last, not just the Doppler. We look at Dopplers, we look at the blood pressures, and we look at PLGF levels. All 3 are very, very important for us.
Okay, thank you. One doubt I have. One more doubt is like, there was a scan around 20 weeks and the cervical length was borderline 3 centimeters.
Okay.
And three days later, again, the scan was repeated. Suddenly there is os is open and then the cervical length is 1.9. Is it
That
possible?
is what I'm saying. It is possible. When uterus is contracting, how does the preterm labor means what? Uterus is contracting and cervix is being taken up. That is what I'm trying to tell you from that time. There are cofactors, many factors involved. One, contraction of uterus, one, length of the cervix, and the cervical ripening. I would use the word ripening. Ripening means the content of the cervix. That is the reason when you give 3 also, we have to look at not just time, progesterone, uterine quiescence, see progesterone, why am I insisting so much on progesterone is we give it along for the 4 actions. One is it is the hormone of the pregnancy, so it's a uterine quiescent. It is a cervical length enhancer because of the increased content of the cervix, and it is an immunomodulator. Apart from being the main bed and breeder for the baby through the placenta. Okay, so it causes the hypertrophy of uterus. That is what it is. Whereas hyperplasia is by estrogen, hypertrophy is by progesterone. Okay, so if we don't give progesterone if there is a coincidental infection or something going on, it can be intrapartum sepsis, it can be UTI or anything which is irritating, and uterus has gone into contraction. How is the baby going to come out? Cervix has to be taken up and cervix has to open up.
Yes.
So that's why I said, unfortunately,
theoretically, the size they tell is 30 to 40 is normal. Then when there is 30,
yes, that is a second trimester. I look at it as very, very. First trimester, I give 30 as the normal. Second trimester, if it is not 35, 36, I am very skeptical. I put off on progesterone. That is what I look at. So high degree of suspicion is needed. And the patient's past history, if she had a previous preterm delivery, is very, very important. And what sort of work she does is also equally important. And I think the doctor has to look into all the factors rather than one. Like I said, unfortunately, we don't do elastogram of cervix. That is a very important point. We cannot do it. So that is what is the main important.
Yes, ma'am. We'll definitely look into this elastography point, ma'am. It's really useful. And thinking out of the box.
Yes, you have to think out of the box to give the solutions to the patient. When a 3 centimeter and the cervix has become ripened, the contents of the cervix will become, more of liquid, more of collagen will be less, and more of these things, soft tissue will be there. That is a cervix which can be taken up very faster. It's like Bishop's course. You know what if you remember gynecology when you read in MBBS.
Forgot them now.
I know. Any more questions from anybody else?
I don't see any questions from the
Hands
audience,
raising,
but
yes.
I'm really thankful that in spite of
Thank
you
you.
hosting a surgery at 5 o'clock, you took time and you came out for this
No.
clinical discussion, clinical radiological discussion.
Yeah.
Thank you once again, ma'am.
Thank you, Vijayanand, for having me. Thank you,
Thank you,
Rohan, for a
ma'am.
fantastic presentation. Bye.
The pleasure is all mine, ma'am. Thank you so much.
Thanks, Rohan.
Bye.
Thanks, Rohan.
Bye.
Thank you, everyone.
Yeah.
Yeah. Bye.